welcome everyone to our Survive and Thrive webinar series. I am Rachel Perkins, the Education and Outreach Specialist for Texas Oncology Foundation. If you are a cancer patient, a caregiver, or a professional and want to educate yourself on anything about the cancer world, we invite you to subscribe and join us every second and fourth Tuesday of the month. We're so glad to have you all with us today, and we are excited to hear from Kanisha Harewood and Melissa Struby discussing finding hope in hospice care. So I'm going to do a little bit of an introduction for the foundation. The Texas Oncology Foundation is dedicated to providing support to cancer patients in communities where they live, work, and receive treatment. Through Survive and Thrive programming, the foundation can provide educational events like this one and resources to help build community connections and support all affected by cancer. So I'm going to go ahead and introduce our speakers today. Today we have Melissa Struby. She's a licensed master social worker for Texas Oncology at Central Austin Clinic. She has 30 years of experience with over 20 years experience as a social worker. Melissa has worked in community health education, school social work, medical school social work in the hospital, and home health hospice, and she's now in the oncology setting. While working on home health, Melissa specialized in end-of-life care and is passionate about supporting patients and their families as they navigate an uncertain future. Melissa enjoys spending time with her family, her fur babies, and her good friends. She loves music, travel, and the Green Bay Packers, and exploring all the fun things the city of Austin has to offer. We also are here today with Kanisha Harewood, who is a licensed clinical social worker and is certified oncology social worker. She earned her master's degree from the University of Michigan School of Social Work in Ann Arbor in 2017. Kanisha has worked with Alzheimer's and dementia patients and their families in hospice and currently in oncology care. Kanisha serves the San Antonio region of Texas Oncology as a clinical social worker. Her passion for oncology care stems from a childhood loss of a parent. In her free time, Kanisha enjoys traveling with her spouse and binge watching 90s shows. Kanisha's practice as an oncology social worker is guided by the following principle: seek justice, love mercy, walk humbly. So Melissa and Kanisha, it is such an honor to have you here today. When you are ready, feel free to share your screen and introduce yourself.
Hi, I'm Melissa Struby. I'm a social worker with Texas Oncology at Central Austin.
Hi, I'm Kanisha. I'm the social worker in San Antonio, Texas. And we're so glad that you could join us today.
Okay.
So again, welcome everyone. We are glad to be here and share this space with you to talk about such an important topic. Today we're going to talk about end-of-life care, when to talk about it, what it looks like, and how patients continue to find hope as they make that transition. We're also going to look at a video of a patient and his wife as they have conversations with their provider about their hope for end-of-life care and what that transition looks like for them.
Okay, before we begin, we'll like to talk with you guys about some terminology that we'll be using throughout this presentation. The first is palliative care, improving life quality for patients with serious illness. This is typically referred to as pain management. End-of-life care for those entering the last phase of life, and hospice, which we'll be talking about in more detail, a model for delivering end-of-life care.
So now we're going to start with a clip from a show from Frontline's documentary, Being Mortal, which follows the author of the book, Being Mortal, Dr. Atul Gawande, as he explores why doctors struggle to discuss end-of-life care and death with patients. And here in this clip, we will see Jeff and Genie as they work with their provider on their wishes for end-of-life care.
When I first learned of Jeff Shields, He had already gone through 3 years of treatment for a rare form of lymphoma. Chemotherapy hadn't worked. He hadn't given up hope, but he was also recognizing that his odds were diminishing, even as his doctors were offering him more treatment options.
Well, my experience has been that oncologists, at least my doctors, are basically optimistic. And they're always looking for a way to push the disease into remission than they are in talking about the longer term picture of mortality. I spent time talking to Genie, my wife, thinking about, at least for me, I want to make a decision. I don't want to linger.
We've had conversations about all aspects of what the end of his life might look like. And most of all, he says, I want to be at the farm. And, hopefully I'm in a position to make sure that happens. We have an appointment that I hope will result in them saying that the disease is lessened, but they might say, no, it's not under control. And then we're going to start having a conversation about mortality. And because I don't think there are so many more choices for Jeff in terms of treatment.
Hey, Rob.
Hey, Jeff.
Hi, Rob.
Hey, how we doing?
Good.
Okay,
Thanks
good.
for coming over.
My pleasure.
Any results on the biopsy?
Yes. The preliminary results do look like graft versus host disease. And that's not necessarily so surprising. We expected that. I first met Mr. Shields about 2 years ago. At that point, he had a bone marrow transplant. And unfortunately, about a year after the transplant, he showed signs that his disease was coming back. In addition to that, he has a complication of transplant where the donor cells are actually attacking his body. And unfortunately, it's wearing him down. It almost goes without saying, but we may have to make a new game plan a week from now.
To feel really crummy or spend the last 3 or 4 weeks of my life in the hospital is not very appealing to me.
I bet not.
And so when we get to that point, I'll rely on you to make sure we have that conversation.
Right. And it's a group discussion for
It sure
all of
is.
us. Yeah. All right. We'll see you guys.
It's always a hard thing, right? How do you know if they're coming towards the end versus changing the therapy again?
Well, I don't think we ever know.
Right.
With Jeff, he was a very thoughtful fellow, and thoughtful in the sense that he had considered what might happen down the road. And he made it very clear to me that if we thought some therapy might be helpful, might prolong his life with reasonable quality of life, he was happy to go for it. He also made it very clear that if we thought that things were going to go badly, or if things looked like they weren't going to work, he didn't want to pursue therapy just for the sake of pursuing therapy.
We're going to transition into when should we have conversations about end of life. From the video, you heard that the patient was talking to his doctor, and the doctor understood exactly what the patient wanted. So we wanted to dive into that a little bit more. All right, so conversations should happen before the onset of a serious illness, because you'll have a clear mind to make decisions. You have family or support system conversation, and this would be a good time to start talking about living will documents, medical power of attorneys, durable power of attorney, and out of hospital do not resuscitate orders. We're going to transition into another time that we could talk about end of life care. So before treatment begins. You are the driver of your care. What brings you joy in life? What do you hope to continue doing? What milestones or future events are you looking forward to? It is important to discuss with your care team your treatment goals and have a goals of care conversation. These conversations should be ongoing. During treatment, once treatment begins, you may realize that you experience unpleasant side effects, or maybe you don't experience side effects at all. Maybe your ability to engage and prefer activities, it shifts. And life transitions happen. Sometimes people get divorced, sometimes people get married, you lose your job, you move closer to where treatment is. So all of these are examples of reasons why you'll continue to have these end of life conversations with your care team. And lastly, when treatment is no longer effective. By the time you've reached this point in treatment, you and your care team have had regular conversations about your goals and desires. This is the best case scenario that you have had regular conversations. Throughout these conversations, your desires may have shifted or remained the same. Together, you and your care team can have conversations about next steps, a different level of care. And we're going to transition into talking about hospice, which is what a lot of people transition to once treatment no longer is effective.
So the philosophy behind hospice care is it's a philosophy of care that accepts dying as a natural part of life. When death is inevitable, hospice seeks neither to hasten nor postpone it, but to provide the resources to ensure as best they can that the final life experience is supported by knowledgeable professionals. Hospice care is a shift in perspective. Hospice does not focus on numbers or curative treatments, but rather the focus of hospice is on how the patient defines comfort for themselves. Slide. So what does that look like? Numbers and cents, right? What is hospice care gonna cost me? So hospice care itself is really looking at the last 6 months of life. And it is a covered benefit under Medicare. Medicare typically sets the standards for all other insurances, so we're going to focus on the hospice benefit under Medicare. So with that, when a patient signs on to hospice under Medicare and the hospice benefit, they are switching their care from being under traditional Medicare to now being under the hospice benefit. So all their care is going to go through that. And it covers 4 levels of care. The first is home hospice. It's the most common level of care in hospice. The patient is generally stable, and the patient's symptoms like pain or nausea and vomiting are adequately controlled. This is usually provided in the home setting. The second is general inpatient care or acute inpatient hospice. This is a crisis-like level of care for short-term management of out-of-control pain or symptoms, usually provided outside of the home in an inpatient setting at a medical facility like a hospital, a skilled nursing facility, or a freestanding hospice facility. Next is continuous home care hospice. So that is when a skilled hospice nurse is needed in the home with the patient to provide a skilled care need for 5 hours or longer. This is covered under the hospice benefit. This is a crisis-like level of care, and it's usually provided in the home or where the patient is residing. And last, respite care is covered. And this is a level of temporary care provided in a nursing home or hospice inpatient facility or hospital so that a family member or a friend who's the patient's caregiver can take some time off. This level of care is tied to caregiver needs, not patient symptoms. So all 4 of these levels of care under hospice are covered. Slide. Also under the hospice benefit, all medications related to the hospice diagnosis is covered. So anything related to comfort, symptom management, or medications related to the hospice diagnosis are covered. I want to say at 95%, there might be a 5% copay. Most of the medications used for comfort are generic, and so there's usually typically a very minimal cost for those. Also is covered is all the medical equipment or supplies needed for care. That would include a hospital bed, wheelchair, or bedside commode, walker, oxygen, chucks, depends, wound care supplies. Anything that's needed for the patient's care in the home is covered under the hospice benefit. And also, everyone on the hospice care team is covered under the hospice benefit. Slide. So when we say that this care is provided in the home, hospice will follow the patient wherever they live. This could be in a nursing home, assisted living, hospitals, inpatient hospice facility, at a family member's home, at a friend's house, wherever the patient's living. I've even provided care for a patient in a hotel. So hospice will follow the patient where they are living. Slide. So what hospice does not cover? I always think this is important to talk about. First is custodial care, paid caregivers, or private duty nursing. So hospice does not cover the cost or the need for daily care. So when we talk about custodial care, we're talking about daily care needs of a patient, such as dressing, transferring, cooking, cleaning, or if a patient needs someone with them 24/7 for safety reasons. This type of care is not covered under the benefit. Second is they do not cover the cost of a patient needing to live in a nursing home. So we're talking like if someone is not safe for them to live at home, they need to reside at a nursing facility or assisted living, that is something that the patient will have to pay for out of pocket. That is not, the residential part of that is not covered under the hospice benefit. And then lastly, are any medications not related to comfort or the patient's diagnosis? And so if you have a patient, let's say I'm on hospice related to a cancer diagnosis, but I also have diabetes and I want to keep taking my insulin, that would still fall under my traditional insurance. The insulin, anything related to diabetes or another diagnosis that I have, I can continue to keep taking those medications, but they are not going to be covered under the hospice benefit. So who is on the hospice care team? Well, most importantly, the patient, but also there's a whole wraparound care team around that patient and also their caregiver or family member. Can you go to the next slide? And that's what makes, I think, hospice really special, is to have this team approach, this wraparound care. And hospice is not just looking at patients' physical symptoms, but we're also looking at the patient and their family as a whole person, emotional, spiritual, social, and physical. So on our care team, most important, we have the patient and their family in the center. And all around them, we have their attending physician. And this can look different. Sometimes a patient can keep their current primary care physician, who will continue to serve as their attending physician, and they will continue to direct their care. Some patients choose to switch that to the attending physician for the hospice care team. So that just depends on where the patient lives and what that model looks like for their hospice. Next, reporting to the physician is the nurse care manager. So a patient on hospice will have one primary nurse, their nurse case manager, who they will really get to know. And it is that nurse's responsibility to be the eyes and ears for the physician and to really work with the patient on managing their symptoms in the home. A patient will also get to know probably one or two other visiting nurses as well on the care team for when that nurse case manager can't always make the visit, or if it's a weekend and they're getting visits from a weekend nurse. But there's usually, I'd say, maybe two or three nurses that a patient will get to know really well on their care team, but one primary nurse case manager. You will also have a social worker on the care team, and the social worker works with the patient and the whole hospice team on assisting with coping strategies, long-term care planning, support and counseling, resource linkage, advanced directives. They just really kind of work really closely with the patient and their family and walking with them. We also have a chaplain on the care team. They kind of address, I always like to say, the matters of the heart. They're state certified chaplains. They don't represent a religion or a specific church. They are really just to address spiritual support and to walk with a patient spiritually through end of life. And, it's not uncommon for a patient and their family to already have a strong faith community or a pastor or a priest that they're close with and already working with. And the hospice chaplain can also maybe sometimes serve as that linkage, or if a patient's wanting to reconnect to a church, the hospice chaplain can kind of serve that bridge of reconnecting a patient to their faith community, or pulling in a priest if a priest is requested. Next, we have a volunteer coordinator. So hospice requires volunteer support for socialization and support. That could be visits to a patient and their family. Sometimes they can also provide a little bit short-term, like 1 or 2 hours of respite care if a family member has an appointment they need to make and they need someone to sit with the patient. So there's different ways to use volunteers, and I'm going to talk a little bit about that as well in the next slide. And then the medical director. So there's also another physician that's following the hospice care team. And this physician, the medical director, meets with the hospice care team every 2 weeks, and they staff each patient to ensure that hospice is still an appropriate level of care. So with hospice, since we're looking at the last 6 months of life, we have to be showing that there is some decline that is occurring. And over time, if things kind of plateau and there's really no more decline, then hospice may not be appropriate anymore. So there is a medical director that's following along with the team. And also the medical director is really another valuable resource for our nurses if a patient is having symptoms that they're struggling to manage and everything that they're trying isn't working. That medical director can also provide other suggestions or interventions to try. They're a really valuable resource. So on the next slide, I'm going to talk about some additional support resources that are available through hospice. So pet therapy is one. Some hospices will offer pet therapy, massage therapy, legacy work with the volunteers. So it could be scrapbooking. We have one called Every Life Has a Story, where a videographer would go out and interview a patient. The patient would be able to pick out different questions they wanted to be asked, and they would make a video and kind of capture different stories from a patient's life. Build-A-Bear, where a patient could make a recording of their voice and have it where the grandchildren or children could then take a gift certificate with that recording box to Build-A-Bear and have a bear built with the little voice recorder inside. Letter writing, and here's where with Texas Oncology, I'm a firm believer that we don't have to wait until we're on hospice to start working on our legacy work. We've started partnering with the mentors and meetups and doing legacy work beforehand. So now we're going to go back and look back at Jeff and Genie. and see where they are and take a look at what hope looked like for them as Jeff transitioned to end-of-life care.
As this home time began to unfold, I began to realize how difficult it was. What do you think? We have to test this. Partly because our house was not organized or arranged to comfortably do this. You know, suddenly you have a hospital bed in the middle of your living room.
Then I need you to help me bring my feet up.
Don't know that.
Here, Malcolm, we're going to help Pop-Up take his slippers off. Can you do that? You want it to be as comfortable and happy a place for him as it can be. And at the same time, it's, you know, it's sort of the elephant in the room.
You know, at that camp,
All right. Okay.
Just lean back.
Okay. Have I talked to you at all about my thoughts on dying? And
No.
is it too hard? Okay. Let me just tell you this. I'm not afraid of dying. I've had a long and wonderful life. And one of the nice things about being at the farm is that you realize everything dies. There's a cycle of life. The cows die, the trees die, the grass dies, the fish die, and people die.
Aren't you sad that you're going to be missing out on a lot of things?
Well, I will be. And, you know, I had hoped to have another 10 or 15 years. But you don't always get what you want, right? I love you.
I love you too.
See you in a few minutes.
In those last weeks, you know, as his space narrowed and narrowed to that bed, it grew in terms of the people he was drawing in. I hate to cry, sorry. But that's another one of those paradoxes, you know, as your world comes closer and smaller, it becomes bigger and bigger. And he was seeing that.
The last couple of weeks, I've been surrounded by family and friends, and it's been terrific. You know, some of the best days of my life, I must say. But then there's a downward trend that's more rapid than I had expected. I felt great during that time, and my body was in rapid decline. Since then, my mind has been in rapid decline. I get confused. But I'm still a happy guy.
Jeff Shields' words about his last weeks being his happiest seemed especially profound to me because they were among his last words. He died just hours afterwards.
So I love this video because it really shows how hope doesn't go away at end of life or with hospice. It just changes. That hospice care is about living life to the fullest. And Genie really described this best As Jeff's physical world grew smaller, his emotional world grew. Jeff was able to die a happy man. And I think largely because he was able to express early on what his wishes were, what he would want for that time. Hospice is about hope for how remaining time is spent. Jeff was clear with his oncologist that he wanted to focus his remaining time on his family, not in the hospitals and clinics, and not chasing treatments. End of life care was able to help honor that wish. And Jeff was able to have these beautiful conversations with his family and really model for them how to die with dignity. Hospice provides this wraparound service and addresses physical, emotional, social, and spiritual needs of the patient, supports patients in redefining what hope looks like. Genie had the support of the hospice care team to be able to keep Jeff at home, and she expressed how hard that is. And this is often a relief for both the patient and the family to have that wraparound support. And if things aren't working, to have that support of the nurse and the social worker to put another plan in place. They aren't alone in making those decisions. And support is provided to all family members before and after death. Hospice will continue to follow families for 12 months after death with bereavement services. This brings a lot of comfort to patients in their final days, knowing that someone is still going to be reaching out to them and checking on them and providing that support. So hope does not go away. It just shifts to something different. Slide.
We're going to shift to some frequently asked questions. Thank you so much, Melissa, for talking to us in detail about the hospice philosophy and the benefit and the hope. So one of the frequently asked questions that we have is, what if I have private insurance? Each private insurance will have their own hospice benefit and not always follow the standards set by Medicare. So you should definitely check with your insurance provider. That also goes for Medicaid as well. Will I still have my oncology team when I transition to hospice? No, you'll be transitioned to a new interdisciplinary team. Can I decide I no longer want hospice? Yes, you're able to revoke hospice at any time and restart treatment if it's in the best interest with your care team. Does hospice mean I'm giving up? No, it means that you're choosing the best quality of life for yourself that aligns with your desires and wishes. Hospice can provide dignity and alleviate suffering. As you saw in the video, the patient was an active part of his decision-making for his care from the time he was diagnosed until the time he decided to choose hospice. And he chose hope and he chose hospice. Thank you so much for joining us for this webinar. It looks like we have some questions in the chat that Melissa and I will be answering.
Yeah, thank you guys for that. I'm really glad that we watched those videos just to kind of give an example for everyone who might not know what hospice looks like or is new to the hospice space. So I think that was really beneficial for us. And I'll go ahead, now is the time. If you have questions, go ahead and put them in the chat for us now. We're here with specialists Melissa and Kanisha. They are experts in the hospice field. So feel free to ask any question as small or big as you'd like for them. Let's start with the first one that we got from one of our viewers today. We got asked, do people with cancer qualify for Medicare, or do they still need to be over 65?
No, hospice would not. No, so they would. So if someone does not have Medicare and are wanting hospice care, they would have to see if their traditional insurance covers it and what what that would look like. Like I said earlier, Medicare typically sets the standard, but some policies don't follow Medicare standard 100%. So they may cover home hospice and acute hospice, but not respite. So you would have to see what your insurance would cover. That's a good question.
Good question. They kind of beat me to it because I also had a question. I was wondering if patients have a choice whether they can use their private insurance or if they are on Medicaid, if they can choose which one they want to do.
That's an interesting. So, I'm sorry. So Medicaid. So I don't think you could have traditional. You couldn't have traditional insurance and Medicaid. You could have Medicare and Medicaid.
Okay, and maybe that's what I'm thinking.
If you have Medicare and Medicaid, it would fall under Medicare, but if a patient had to move to a nursing facility, then Medicaid would cover the residential cost of them living in the facility, and Medicare would cover the hospice care, the medical side of care. I hope that answers the question.
Yes, it does.
And I saw one about diagnosis. So what they typically, in my experience, has been is they will use when a referral, so hospice is initiated by a doctor's referral. So a patient's physician or oncologist, whoever, believes that, yes, this diagnosis, whether it's congestive heart failure, a cancer diagnosis, COPD, whatever it may be, is hospice appropriate under this diagnosis. They will make a referral to hospice. The hospice will then also look at the diagnosis and the medical information, and they will do their own check to see if the patient is, in fact, would qualify under that diagnosis for hospice. But let's say they have multiple diagnoses. They will pick the one that is more likely causing the patient's physical decline. And the reason that we're looking at end-of-life care. So if that would be the heart as opposed to cancer, or the cancer as opposed to the heart, and then they would use that diagnosis as a diagnosis for hospice. Anything related to another diagnosis would still fall under their traditional insurance, whether it's Medicare, a private insurance, or Medicaid.
Kanisha, do you have anything to add to that, to the diagnosis portion of it? Okay.
Sorry, no. But I do see a question that Benny asked about approaching a patient to discuss advanced care planning. And you know, in this webinar, we talked about the different times that, you know, we should be having end-of-life conversations. But typically when a patient, for Texas Oncology anyway, we should be talking about advanced care planning. Even the front desk usually ask, you know, what about medical power of attorney? But in terms of, as social workers, talking about advanced care planning, we may not even have to use the word. Like, what do you understand about your diagnosis? And what does your diagnosis mean to you? Those are conversation starters for advanced care planning, right? Just to get a feel for what's important for the patient. And usually the conversation is about, do you have a medical power of attorney? Do you have a living will? That once you build that rapport, it's a little easier to talk about the legality, the legal documents associated with advanced care planning. How do you deal with patient resistance? I say, ask them about what they value in their life. What do they hope to accomplish? And sometimes when you ask people, like, what brings your life joy, that could definitely be a conversation starter for advanced care planning. It's what I've found in my work. Melissa, do you have anything additional?
Yeah, I've taken a couple of, on top of those approaches, some other ways I've attempted this conversation is really looking at the legality of it, that, you know, in some states, families do not have legal privilege. So in Texas, family does have some legal privilege, but in other states, they don't. And if you don't have some of these documents in place, your family is going to have to go to court and pay money to be able to advocate for you if needed. And by doing this paperwork in advance, you have a say. And whoever you designate to honor your wishes have to do just that and honor your wishes. And so I try to take that route sometimes, and usually that will get someone's attention. But you got to go at someone's pace, right? You can only present the information.
Yeah, very true. That kind of leads me to a question I typically ask presenters is, we discuss some pretty heavy topics and we discuss some pretty taboo topics for some families. So how do you support someone to start these conversations? I think your response of like asking them what gives them joy is really good, but taking that step further and asking, maybe why do you feel uncomfortable about this? How do you start that conversation so that they can present it to their family in a way that they will understand why we need to talk about hospice care and mortality?
That's a good question. One of the first things that come to my mind is the fact that there's one thing we're all promised, as morbid as that sounds, and that's that we have to go, right? Like we're not here forever. And, life is so unpredictable too. So, you could be driving and something can happen, right? So we should always be planning for the worst case scenario, and not necessarily in relation to their disease, but normalizing it, right? About the things that happen. You get up, you drive to work, and you don't know if you're going to get there, right? But what if you had a plan for what would happen if you didn't make it, right? It'll make it a lot easier. Our director, Stephanie, says that it's a love gesture, right? So your family doesn't have to keep guessing at what you would want. And then, there's discord among family too. So yeah, I'm hoping that helped answer your question.
Yeah, it does. It does.
I
I
have
like
found
the promise. Like it's something that it's a promise.
Yeah.
I have found it to be more the reverse, where it's the family that's wanting to know what the patient's wishes are, and the patient really not ready to go there mentally or emotionally with their family. So it's takes kind of everything you just said, the rapport building. Yeah, so they feel comfortable.
We do have another question in the chat. How do you address complex family dynamics? For example, a patient's younger adult child is the MPOA, but then the patient's estranged oldest child from out of state wants to be the decision maker. So how would you kind of navigate this?
I can't tell you how often that happens.
Oh no. Oh no.
It does happen a lot, and it's not uncommon where this, out of town family member wants to swoop in and kind of start running the show. And it's tricky. Just a lot of family support will often help, facilitate conversations. And at the very end, sometimes it comes down to legally, this is what has been arranged, and this is what we have to honor. So that's where having these documents in place, it's when we don't have advance directives in place, when a family member from out of town swoops in and wants to take over, where things get even more difficult. But having those documents in place, it's a little bit easier of a conversation, but sometimes it's just having those family conversations, help facilitating that and providing that support, helping maybe sometimes the patient and family members help give them the strategies of having those conversations. Yeah, it's a good question, and it happens all the time.
Yeah, I know in our caregiver survival group, we kind of talk about how to run a family meeting. And so I could definitely see that being beneficial in this scenario. So I also had a question about legacy work. Shameless plug. We do mentors and meetups in Austin, Texas. We'll be doing it every Friday in February, where we do legacy work, including cross stitching. Melissa and Kanisha, I know we've had this conversation before, but can you give me some creative ways of legacy work that maybe isn't crafting, but something else that you can do to leave behind for other people? And also maybe something that you guys have done personally.
I'm going to jump in on this, Kanisha. One of my favorite things that we would do in hospice with patients, especially patients that felt like they weren't leaving a ton of money, like that material side, excuse me, to their family, but were struggling because they didn't feel like they were leaving anything. Because we would do a values will and try to capture all the things that were really important to them, life lessons that they would want to pass down to their children and grandchildren. And patients really got a lot of meaning from that and really appreciated doing that. That's one of my favorite ones.
So how would you start a values will?
You know, there's you can look it up online. There's samples online, and kind of goes through and has questions to answer to kind of help you formulate that. Yeah.
Cool.
Mhm.
And then Kanisha, what is your favorite way to leave legacy or have legacy work?
Okay, so I'm actually working with the patient on this now, and she cooks with her children. So a cookbook. She's been taking pictures of her kids whenever they cook together, and she's going to put the recipe right next to those pictures, right? Um, so that her children remember her. So I don't know. I'm really excited about that. And
That
her
one just
making
gave me
aprons.
chills.
Huh?
That one just gave me chills. Just like, oh, that's a good one.
That is the good one.
Mhm.
It looks like we have a question in the Q&A.
Mhm.
I'm unclear still about what hope transitions to in the hospice space. Are we saying hope is hope for passing away with dignity, or hope to be pain managed, or more or something else? We have a palliative hospice care team right now, but they only come by once a month. So I'm not sure how to truly utilize this care. That's a good question.
That's a good question.
I think what we're trying to say is that hope just changes. I think while we're in treatment, we're very focused on we hope the treatment works. We hope the treatment works. Well, if I'm not hoping for that anymore, what am I hoping for? And so it's kind of redefining what are we hoping for now? Are we hoping for more time with our family, or are we hoping for making it to the next birthday? Are we hoping to be able to be at home as long as possible? It's really kind of trying to redefine what that hope looks like. And sometimes the hospice care team, they can really help facilitate that, and they can help a patient redefine that hope. There's another part to that question. I lost it. It went away.
The second part is we have a palliative hospice care team right now, but they only come by once a month. So I'm not sure how to truly utilize this care.
Yeah, palliative care is a little different from hospice. So, palliative care, they're not quite that wraparound in the same way as hospice. I don't want to say they don't, but it's not as frequent. It's you I think there's a social worker sometimes, but they don't maybe always make a home visit. So I think that is a tricky question with palliative care. Probably having that conversation with the palliative care nurse and seeing who else on the palliative care team you would have access to, and trying to enlist them.
Kanisha, do you have anything to add?
No, I think what Melissa says, I agree with. So,
Okay. All right, then that will be our last question for today. I just wanted to say thank you for everyone who participated with us today. It was lovely seeing you all, and you had such great questions. So just a reminder, this session was recorded and will be sent to all registrants in the follow-up email. And it's also available on our Texas Oncology Foundation website. I'm actually going to share my screen with you guys now so that you can see where to find these. It's always up here on our bottom left, Survive and Thrive webinar. But you can also go to education and go to the Survive and Thrive webinar that way as well. It has upcoming webinars. It has previous webinars. You can still see today's is up there. In December, we have a couple coming up. We have Holiday Resilience, Thriving Through Cancer with Dr. David Zuniga. And then we will have a pre-recorded webinar with a free 20-minute meditation with Dr. Zuniga on the 26th. So after your holiday season and you just need some 20 minutes to relax, come join us and we will have a holiday meditation for you guys. Just a reminder that you can like our Facebook page, which you can get to at the bottom right here, Facebook, Instagram. Follow us there. And just in, view of today's topic, we would like to share resources for those of you who have lost a loved one to cancer. So our support groups can be found under support here. We have Grappling with Grief, which is our bereavement support group that meets every first and third Wednesday of the month. As a caregiver going through hospice or palliative care, I do highly suggest joining our Caregiver Connection support groups or our 6-week caregiver survival group as well. So there's a lot of options and education options for you guys if you're looking for support. We also already mentioned this, but we have Mentors and Meetup in February. It's a hybrid experience and it's in every Friday in February at Austin, Central Austin at the Balcones location. We're doing cross stitch this time around. So if you guys sign up 2 weeks in advance, we will send you some cross stitch to do with us during that time. So we are actually really excited for that. Let me make sure I got through everything. Oh, and then lastly, we value your feedback from our community. In the follow-up emails, there will be a link to a survey. Also, when you exit out of this, there'll be the link to the survey there as well. But please let us know what we can do better in the future. If you loved it, if you thought there was more questions, we can ask those as well. But this is the space, I put it in the chat to everyone, where you can go ahead and give us some feedback about our Survive and Thrive webinar today. So thank you, Melissa. Thank you, Kanisha. I'm so glad that I was able to do this with you today. You got a lot of great feedback. I see everybody in the chat that's saying thank you so much. So we will see you guys on the second Tuesday of December next month. So bye, guys.